Thank you, Joost. Good morning again. In the next 10 minutes or so, I would like to show you some examples of the use of machine learning techniques in clinical neuroimaging, in psychiatry. And I would like to discuss two problems you can encounter. So let's start to a simple example, what you can do usually with machine learning in psychiatric imaging. You have an imaging data set of some subject and you want to make some prediction, let's say diagnosis. So that could be classifying a person as being healthy or having schizophrenia, or making a differential diagnosis, splitting between schizophrenia and bipolar disorder. Well, this talk will be about the right and left-hand side of this process. So not so much about the algorithm we use, the machine learning techniques. So that's why it's depicted by a black box. So, for example, you can try to classify people based on their image in three categories: healthy subjects, bipolar disorder, or schizophrenia. We have done that in our data set, and you can reach reasonable prediction accuracies depending on which two categories you want to discriminate from each other. You can reach accuracies between 70 and 86%. It's not bad, but far from perfect. And it's important to realize that this is done in chronic patients, adults who have been ill for quite some time. While it would be more clinically relevant if you could do this in first episode patients who haven't been ill that long. And it will be even more relevant if you could do that in high-risk subjects, so in adolescents when the disease starts to show up, if you could do it there. So we tried that as well in our offspring sample. These are adolescents who are offspring of healthy subjects, subjects with bipolar disorder, and subjects with schizophrenia. And you see that, again, you can reach modest, reasonable accuracies when trying to split this group. But you see, again, it's far from perfect and even a bit lower because brain abnormalities are more subtle in these subjects, of course. So could we reach a perfect classification? Well, the answer is, of course, no. And one of the main problems is the gold standard. If you use supervised learning in psychiatric imaging, you need a gold standard, which is the labels given by the experts, the psychiatrists in our case. And you can, of course, never do better than those expert labels. And there has been an interesting publication by Regier and colleagues some 5 years ago. We investigated the reliability of the diagnosis. What you can see is that there are some disorders with reasonable inter-judge agreement, but there are also quite some disorders with modest and even very poor inter-rater reliability. So the gold standard is not really gold, but not even silver sometimes, maybe wood. But we have to deal with that if you want to do supervised learning. So this is the schematic overview of that. You think of a patient having some true phenotype, and you want to make a model linking the brain measures to that true phenotype. But in practice, you have to work with some constructed phenotype, DSM diagnosis, and even worse, you have to measure that phenotype. And that's prone to bias, variability, noise. Measurements always carry noise with them. And of course, it's an artificial construct. So this link may be much weaker than you hoped for. So one solution could be to use a more reliable label. And one option could be use of age, which is, of course, a quite reliable and hard label. It's also automatically a transdiagnostic label because it's non-specific to certain diseases. So that has been done already 10 years ago, and since then many times, predicting age from brain scans, which is called brain age. For those who are not familiar with that, here's a short overview of how that works. This one. You start with a large bunch of healthy subjects of whom you have brain scans and their age, of course, and you train, in our case, a support vector regression machine to predict their age, and you obtain brain age. So the result is a brain age model, and you can apply that to new subjects, their scans, to predict their age. And you can compare that with their true age, and the difference is called the brain age gap. And the idea is that that is informative of the health of the subject's brain. So indeed, you could apply it to scans of people with schizophrenia, and what you then indeed find is that the brain age is on average about 3.4 years older in patients with schizophrenia as compared to their chronological age. So let's apply that to the adolescents, the offspring sample, which you see at the bottom. So let's see if we can already detect an increased age of the brain in these subjects. And indeed, you see very mild increases in schizophrenia, somewhat more than in bipolar disorder. But compared to the healthy subjects, the offspring of the healthy subjects, you see indeed already that their age is a bit increased. So this could be a promising marker to detect problems in those subjects. So that's the one problem with a possible solution. Go to much more reliable labels than the diagnostic labels from the psychiatrist. The other problem is on the other side of the picture. If you do imaging for machine learning applications and other applications, of course, as well, you have to make many choices. It starts already with which imaging modality you use, which scan, and then you can choose from a big bunch of processing options to retrieve your features for your models. And those choices affect the reliability, the accuracy, the interpretability, and so on of your prediction models. So the picture is a little bit more difficult than shown here in advance. If we look at the imaging part, it looks more like this. So on top, there's the true phenotype, which you would like to link to some true substrate, your brain cells, your networks in your head. This is what you want to model, but in fact you have to go all the way to measure that substrate in your brain. You get MRI scan in our case, and then you have to process it, segment it into gray and white matter, for instance, reconstruct the cortex, and then you can further apply it. As seen in the previous talk by Joost, you can choose from a wealth of imaging metrics. You can apply atlases to it in higher and lower resolution, and in the end you may extract your features, for instance ROI-based volumes of the cortex, and then you build your machine learning model to predict something. So you can do that for age, and we chose three processing flavors in our study, which are shown here. So we had a high resolution, high dimensional voxel-based data set. So the gray matter density voxel-wise were our features, and we fed that into a support vector machine to predict age. So that's more or less like I showed you before. But we also did some other processes. Instead, we used FreeSurfer to obtain a high dimensional surface-based reconstruction of the cortex, shown here, and we fed that into our brain age model. And finally, we applied the Desicant-Killienne atlas to arrive at a low-dimensional surface-based feature data set and try to predict age from that. So here are the results of that study. On the horizontal axis, you see the number of features of our feature data set, and on the vertical axis, the prediction error, the mean absolute error of our brain age models. So the lower, the better. And what you can see is that the VBM dataset, the voxel-based gray matter density dataset, performed best, had the lowest prediction error. But it has a very high dimension, that dataset. You see the other high dimensional dataset, the vertices from the surface-based reconstruction, has a poorer performance, and the RY-based feature set shown here is more or less in between. The big advantage of the RY-based dataset is, of course, that it has a very low dimension. It's easier to handle. But it carries less information, so that's probably the reason why the performance is not as good as the voxel-based dataset. And the question is, why does the vertex-based dataset perform not that good? I think it has to do, it can have to do with the fact that we use 1.5 Tesla images, so the quality is good, but not as good as 3 Tesla datasets. So maybe the reconstruction of the cortex is not reliable enough, and that has an effect on the reliability of the model. So that's one side of the picture. The other side is that you can look at the weight maps, so based on what is age predicted in these models. And on the left-hand side, you see a typical weight map for voxel-based models. It has a high resolution. There's a lot of detail in it. It's very complex, difficult to visualize. Everything is in there, but it's not that easy to handle. While on the right-hand side, you see the weight map of the RY-based brain age model, which is much more easier to deal with. You can immediately see what is happening and on what regions your aging model is built. So to conclude, I'll show you a few examples of the application of machine learning techniques in psychiatric imaging. And there are 2 problems, or I should say at least 2 problems. I treated 2 problems today. One big problem is the gold standard, that we have to rely on labels provided to us by the experts, the psychiatrists, which carry quite a few issues with them. Solutions to deal with this can be found by using hard labels, diagnostic labels such as age. And the second issue, I treated that there's quite a long distance between what you would like to model and the way you have to go to in fact can do that exercise. And in that long way, you have to make a lot of choices for image processing and feature extraction, and they have an effect on the accuracy and the interpretability and the transportability of your models. And in this study, so I have to stress that it's only one study at the moment that we carried out. We found that the voxel-based morphometry dataset had the highest accuracy of our brain age prediction model, but it is not that interpretable, and it's certainly not easy to transport to other labs, for instance. The service-based model would potentially be a good candidate, but it turns out to have not very high accuracy. But the model is very interpretable. It deals with features that are in millimeters. So cortical thickness, for instance, is 3 millimeters, and the effect, the variation is 0.1 millimeter, for instance. So you can really talk about neuroscientific measures there. And the more easy to handle model is, of course, the RY-based, the Atlas-based models, which was not the most accurate one, but it's very interpretable and, of course, also very transportable. So let me finalize this talk by thanking all those people who contributed to this work. Especially I'd like to mention Rachel Brouwer, who did the work on the brain age model with the different kind of feature types. Thank you for your attention.